Perspective on Florida Gateway College Television is sponsored by Potash Corp of White Springs. Potash Corp, helping nature provide.
Hello everyone and welcome to Perspective. This is a public affairs presentation of Florida Gateway College. My name is Mike McKee. My guest on the program today is Dr. Iyer. She is a hematologist and oncologist at Cancer Care of North Florida. We're going to tell you what her specialty is when we come back. Don't go away.
Can you help me with this? My new dad teaches me all kinds of stuff.
Sure.
He helps me with homework.
That would be 3.6795.
Thanks.
Yep.
He helps me with my decision making.
I wouldn't use this one. Ever.
And he's even teaching me how to drive.
And that's why cars have bumpers.
I'm learning so much.
You don't have to be perfect to be a perfect parent. Thousands of kids in foster care will take you just as you are.
Dr. Iyer is a hematologist oncologist at Cancer Care of North Florida, and we're going to talk a little bit about some cancer treatments that are out there, the ever-evolving world of cancer treatment on the program. Welcome. How are you?
Thank you.
Welcome to
Doing
Lake
well.
City.
Thank you very much.
Dr. Iyer, you've been in Lake City for a couple of weeks?
3 weeks now.
3 weeks, and your specialty is hematology, which I know because my wife was a medical technologist in a laboratory. It was study of the blood.
Right.
And oncology kind of fits in with study of blood
Cancer.
diseases of the cancer type.
Yes.
So is that what you do?
Yes, basically anything related to cancer and blood-related diseases. The hematologic diseases could be cancer-related or non-cancer related. Basically, it's malignant heme or non-malignant heme.
Now, when most lay people think of blood disease, they automatically think of leukemia. Is that the only blood disease that's out there?
Not at all. I would actually say it's it's common, but not as common as the non-malignant hematologic issues. You have anemia. Basically, you have red cells, white cells, platelets in your blood. So you can have high white cells, low white cells, high red cells, low red cells, high platelets, low platelets, bleeding issues, clotting issues. All of these can come under non-malignant hematology.
Well, without doing a biology refresher course, explain the difference. You mentioned platelets.
Uh-huh.
From what I understand of the basic biology that I took in school, which was many, many, many years ago, is that platelets cause blood to clot, right?
That's right.
And
that's
so
right.
talk about that. When you cut yourself, you want to have platelets that are...
Right. You want to have functional platelets that actually help clot blood. Basically, your blood needs to flow at some times and it needs to clot at some times. So your body is in a very exquisite hemostatic balance, if you will, where you have the pro-clotting elements and then you have the anti-clotting elements. So there are conditions now if you want just platelets, because you have both platelets as well as clotting factors. They're all important in stopping bleeding. So if you take platelets, you can have platelets that are high in number, low in number, based on either bone marrow issues, or it can be medication related, or any extraneous factors. Infections can make your platelets low, or it can be immunologic issues where your body is fighting your own platelets, so your platelet count is low, which can also lead to bleeding issues.
Okay, well that's kind of what I was going to get at. If you cut yourself shaving, that could be very dangerous, or you cut yourself fixing dinner.
Sure.
You could...
It depends on why you're bleeding more than normal. Is it because your blood vessels are not okay, or is it because your clotting factors are not okay? Is it because your platelets are not okay? And if they are not okay, is it because you're actually taking a medication that's making them not work well, which you may need it to avoid clotting in other states? So somebody who's had a stroke, somebody who's had a heart attack, you don't want them to be able to clot their blood very quickly. So that's why you're putting them on medications that would make it difficult to clot.
When someone has a stroke, they normally put them on a blood thinner, correct? And same thing with heart disease.
With
when
heart
you're having,
disease as well.
When you're having if you've had heart surgery, you don't want there to be a clot because that can cause problems in
That's
itself.
right, that's right.
So your job is to regulate, to make sure that
Right.
all of those things are working, and the fine-tooled
Kind
machine.
of fine-tuning
Right.
whether somebody needs to be more on the clotting side or the bleeding side, depending on the whole body, what their risks are.
Well, and this is what's crazy about medicine, is that everyone is different as well.
Absolutely.
Every body reacts differently, and so you're kind of trying to figure out what's going to work for.
Right,
And-
right. You have to customize everything depending on the situation, the patient, and it may also change with time for the same patient. Say somebody comes with a blood clot. Then you have to find out, are they clotting because of an immediate risk factor? Maybe they were having surgery and they were laid in bed, so they were not moving, because of which you had a clot. Or did they have a catheter or some foreign body that led to a clot forming? Or were they on medications? For women with certain diseases or certain risk factors, they have birth control pills, they can have blood clots. So then your treatment at that point would include taking away the risk factors, and depending on whether it's a big risk, is it a static risk, it's a dynamic changing risk, you decide how long does that person need to be on blood thinners. You don't put everybody on lifelong blood thinners either, because then the bleeding risk becomes more.
Right.
So, and that's, again, it comes back to your point about personalizing each situation.
Now, we mentioned leukemia, because that's the first thing that comes to a
Right.
lot of folks' mind, and that's a disease that your bone marrow is not functioning like it should, and so it's sending cancerous
It makes
blood cells.
abnormal white cells. That's basically leukemia.
And let's go back and take that biology lesson. The white cells do what?
The white cells help fight infection.
Okay.
They help with your immune defense for the body. And leukemia, again, is this one, it's this one big bag where everything gets dumped in. You have acute leukemias, which can kill you right away. But you also, unless they're treated, and even in that there are different classifications, and treatment depends on, what your risk factors are, what your chromosome changes. I mean, there's a lot of nitty-gritty into it. But you also have chronic leukemias, and some of the chronic leukemias, we don't do much. We just, because people live with these for a long time rather than actually die from them. So it's something that we monitor. I mean, I always tell my patients, a common occurrence is the primary physician does routine blood work. They find an abnormality in their blood counts, and they say, oh, your white count is abnormal, you need to go to the hematologist. And then they get a call from our office, which is Cancer Care of North Florida. So it's this, do I have cancer? There's this panic going on. And sometimes the issue is cancer, sometimes it is not cancer. And sometimes it can be cancer, but it's cancer that does not need treatment right away. So really, you should not jump to conclusions till you see your doctor.
Yep, because you're absolutely right. When people hear cancer, they always go to thinking the worst thing is going to happen. But you may have had a heart cath.
Right.
And the doctor is reading your medical test and says, ooh, your white count is this way. I think I need you to see a specialist. So they may refer them to you, and then you say, you do
try
more
to find
investigation.
out why the white count is abnormal, which may or may not be related to the heart procedure. And in some patients, their prognosis may be better from a hematologic standpoint than the heart issue by itself. I mean, a lot of times, just because it's cancer doesn't mean it's a life sentence, whether blood diseases or cancer.
Let's talk about, you mentioned some diseases with clotting factors. I think of hemophilia. Do you treat hemophilia at all?
It's more a disease of it's in childhood. So generally it's pediatric hematologists who treat them. So we do at times, and there are some issues where when they get because hemophilia is basically you don't have a specific clotting factor. So you get replacement from the factor. And occasionally patients can have produce antibodies to the factors they get. So they actually they don't use that, or they can have further bleeding issues. There are some of those issues that we do look at. There are some acquired factor inhibitors which behave like hemophilias. which we do treat, but it's probably less than the pediatric oncologists. And a lot of the children, as they become adults, they know how to treat themselves, and so they are actually better than
the physician of treating
Exactly,
themselves.
yes.
Now, you also were talking about, before we came on the air, the oncology part of the practice is that you're treating symptoms of the treatment
Yes.
as well. So talk a little bit about that, because I think a lot of people, they don't understand there's more than just getting chemotherapy. And there's more than
Absolutely.
just getting radiation. There's a whole thing that you
Right.
don't, behind the scenes
Behind
type
the
of
scenes,
things.
absolutely. I mean, and I'm just going generally.
Sure.
So in general, like I told you before, I mean, 2 out of 3 patients who are diagnosed with cancer can actually expect to live beyond 5 years. So cancer by itself is not necessarily you're dying tomorrow, you're dying in 3 months, not anymore. There are some cancers where we have not made a whole lot of headway, but there are so many new treatments, so many new targeted agents that, I mean, breast cancer, there are some breast cancers that pretty much behave like a chronic disease, you know, where you can keep them alive for years and years and with a good quality of life. But coming to what you were asking, a lot of times when patients come initially, we talk about, okay, you have cancer. Are we going to be able to cure, you know, is our treatment intent, is it curative or is it palliative? Are we buying time, or are we trying to put you through treatment for a short period of time? You may not feel very well, but it is to give you the best chance of it never coming back, right? So that's the first stage. Let's say somebody has had curative treatment, they have completed whatever needs to be done. The one thing that I think sometimes gets lost in the shuffle is what happens afterwards. The treatments that we do give, they do have some repercussions. You could have secondary cancers. You could have physical, emotional, psychosocial after effects that unless you ask, you don't hear from the patients. You know, they
No,
can be.
does you do typically have a follow-up though after?
You do.
I mean, you don't just,
You do.
I'm done with my cancer treatments and I'm not going to see you anymore.
Right. And a lot of patients do ask that, why do I have to see you anymore? Because I'm done and I don't want to come here and, you know, think of bad memories, so to speak. But no, we do have surveillance protocols, we do follow them, and you have to see that they are back into a good routine comfortably.
Well, let's talk about that. You mentioned secondary cancers. Say you beat breast cancer. What could be some secondary things that you as a physician are looking for in those follow-up visits?
In breast cancer, not as many secondary cancers, except maybe old radiation treatments, but there are other diseases where secondary cancers with lymphoma treatments and all that. But with breast cancer specifically, I would say if they have a fairly extensive surgery, removing a lot of the lymph nodes, they can end up with lymphedema. So as far as we are concerned, they have no cancer. But there is this woman walking around with a swollen hand and a less swollen hand, which makes a lot of, you know, psychological impact on the person, pain sometimes. So the lymphedema management is something that we have to watch. Making sure they get back to a better lifestyle. We talked about that too, fitness and diet.
Well, and talk about that. I believe, and I'm probably sort of right, that diet has a lot to do with your health, not just from an obesity standpoint, but some of the foods that I think researchers are looking into some of the processed foods that we take in that may not have been the best for, and I'm going to throw out Cheez-Its or those and
high fat, basically.
high fat, yeah.
High fiber, high fruits, high vegetables with good fitness, maintaining an ideal weight. It's so much easier said than done, but I think not your usual typical meat and potatoes diet wouldn't cut it. You really need to have a healthy and active lifestyle, I think.
Well, and I serve on a health committee with one of our colleagues, Janice Watson, and we were talking about the fact that it's much easier to stop in the drive-through of a McDonald's.
Absolutely, and it's cheaper.
And the kids can eat the chicken nuggets because that's what made them happy is chicken nuggets. But the salads with the fresh fruits and the fresh vegetables and the
They're just not exciting, but
but it's
to some.
you know, it makes you feel better.
Yes.
You know, when people when they eat a good diet like that, they're regular and they're just, you know,
right.
so.
No, absolutely. And I think it's a question of balancing. Maybe for kids, once in a while a treat is okay. But you have, and generally, I would say in my experience, most cancer patients, once it's like an awakening, a second awakening or something. They do reevaluate their lives. And I cannot tell you how many patients come back a year after they've beaten cancer feeling much better than they did before they were diagnosed, because it's kind of, you appreciate the small things in life. You appreciate the ability to go and exercise. You appreciate the fact that you're active enough that you can eat stuff. If they were on radiation and couldn't eat, couldn't taste, and it takes about 6 months to a year sometimes after chemotherapy before your sense of taste comes back, that you can actually enjoy things, and you appreciate it so much more. So it's not that hard a sell to somebody who has had cancer.
But it is good to
know preventatively.
Know that,
yes.
When you're talking about, you know, and I always say to folks, if you think you got it bad, look at someone who has maybe fought cancer and has gone through the radiation and has lost all kinds of weight. And my brother-in-law, for example, had throat cancer, and he has no taste buds to this day. And so think about that, and then think about your lifestyle.
Right.
You would think that if more people would
absolutely
you know, walk in the shoes of someone who has been there, they would.
Usually, yes. I guess you cannot generalize anything.
Right. Well, and I wanted to talk too about the different types of cancers. There are some that are bad. There are some that we've made a lot of progress. You look at prostate. It was brought up at a meeting I was at yesterday that men don't like to talk about prostate cancer. They don't like the exam. They don't like they don't like talking about it. It's just in our DNA. We do not like it. Women, on the other hand.
Oh, we love to examine.
Oh yeah, you know.
You have blogs on breast cancer, but
right. But the women are more likely to
share,
take care, or take care of themselves, but men don't for some reason. And do you see men in your practice that are fighting the disease now and
absolutely
thought that, you know, if I'd have known about this earlier, I probably would have had it done years ago?
Yes and no. I mean, generally you're right. They don't talk a whole lot about, they don't go back a whole lot. The women are the ones who come back with could I have, could I, should I, would I, you know, things like that. I think with men, what I have found is they are stoic, but a lot of times, if once they make up their mind, okay, I'm going to fight this, or I'm, you know, then you cannot move them a whole lot. And with prostate cancer, it's again a very fine line to go. I mean, there's a lot made of screening, you know, at 50 PSA. Excuse me. But now there are some new studies that say if a life expectancy of a gentleman is less than 10 years, then you actually give him a choice. Does he want to be screened for prostate or not? Because you do have very low-grade prostate cancers where you live with it. So early detection is kind of a double-edged sword, you know, and then sometimes the treatments have side effects, again, incontinence, impotence, which is not easy to live with. You may live without prostate cancer, but maybe you would have lived with low-grade anyway. I'm not saying you shouldn't screen, but I'm just saying, I mean, there's kind of a whole gamut of things.
See, and the thing about what you're talking about is that that is discussed. I mean, you're not just going to say this is the way it is. So here's what you have to deal with. You know, are you going to want the incontinence? Is that going to be a problem? You know, maybe.
I mean, which would you rather take? You know, what's your choices? And I think that's how it should be. But coming to new advances in prostate cancer, absolutely. I mean, it used to be that if it was metastatic cancer and they are resistant to hormonal therapy, you had to go to chemotherapy first. But now there are some lovely, well-tolerated oral agents, just pills that one can take, which keeps you, you know, you're not coming every week for chemo or anything like that. You're not losing your hair. You're not doing that. But you're having the disease under control.
Now, I wanted to mention a friend of ours here at the college got skin cancer, and it developed into pancreatic cancer because, you know, and it's...
Okay, so it was pancreatic cancer coming into the skin?
Yeah, according to the diagnosis. So this skin cancer that they found was a mole, and they never got it checked. How important is it to get screened for skin cancer? Because I think a lot of people they think they're just going to get it cut off and that's going to be it, but it can go the other way.
Absolutely. I think screening for melanoma is one of the most important and probably, like you say, undervalued modalities.
Especially where we live.
In Florida, yeah. Your sunscreens is important, probably annual dermatologic evaluation is important. We used to have a saying in our medical school, melanoma doesn't read the textbook. You know, it can go anywhere. It just doesn't follow one particular path. It can skip nodes. It can, so you want to catch it early. You catch it early, you have excellent chance of cure. Once it spreads and it becomes a systemic process, it's a fighting battle.
Now, is that when it becomes lymphoma?
No, they're not the same. Okay. It's more of, lymphoma is different. It's a different hematologic malignancy, which can be both solid with the lymph nodes and spleen, bone marrow, as well as liquid sort of goes, you know, spreading in the blood. But melanoma is, I mean, they're all, melanoma is mostly the skin cells. It starts in the skin, but it can spread via the lymph nodes. So you can have lymph node involvement with melanoma. So.
But it's different in different people, and
it's different. Yes.
It's kind of like there's no similar.
No,
you know, no one is the same in any of this.
Right, and they have found some excellent targets in melanoma. There's a BRAF and a V600. I mean, there are some specific targets where you have treatments, you have pills that actually, I think very recently there was a study with 2 pills, a combination, where if the melanoma had this particular target, more than 70% of patients had an excellent response. So we are getting better, but nowhere near curing advanced stage melanoma.
Are you encouraged by the research that is going on? It seems like there's constant research.
It is overwhelming sometimes, but definitely encouraging.
Because you have to stay up on every single change in protocols.
Right, and then it's, you know, there are so many steps. There's all these protocols, and the pharmaceutical companies have to be able to show clinical data. Is it meaningful to actually translate it in clinical practice? And then is it the big thing, can you afford it? And that's another big, you know, there are studies where you get a marginal benefit. Let's say you get a 5% survival benefit, but the cost is $100,000 or $200,000. How do you decide, is it worth it or not? But how do you decide that I cannot offer it to you? It's a difficult decision both ways. I go with it I give all the information and then make the decision along with the patient. You know,
yeah,
it's not easy.
It's like when you bought that first calculator when you were in high school, that the first one was $300, and you know, and as the treatment develops, the price goes down, and more people are benefiting by that. Again, you're a hematologist, which is looking at the blood, but you're an oncologist as well, and treat all of it. And blood plays an important role. It's the chemo, and the way the chemo is infused, it goes into your bloodstream.
Absolutely.
So,
yes.
I mean, there's some things that having you at the Cancer Care of North Florida is great for an overall practice. You know, having specialists.
It's been wonderful. Yeah.
If you would like more information on hematology, or if you'd like to get some information about potential cancer treatment or alternatives, Dr. Uma Iyer is at the Cancer Care of North Florida. The number is 755-1655. They're located US 90 west of Lake City. And well, let's hope that you don't have to see her, but if you do, she's very pleasant and very positive individual. And I think, you know, if you ask patients, having a positive attitude
absolutely
is what helps you overcome anything in life. But, you know, if you're going through, being depressed is no way to go through chemotherapy or radiation treatment.
Right. So. I think a cup half full is always how you have to look at things.
Well, thank you again for being on the program
welcome.
today, and thank you for
My
watching
pleasure.
Perspective here on Florida Gateway College Television. Until next time, I'm Mike McKee. So long.